Hi, my name is Alan Hirahara from Sacramento, California, presenting on my 7 years of the Superior Capsular Reconstruction. Here's my disclosures. The Superior Capsular Reconstruction was originally presented by Hanada in 1993 and Dr. Mahata in 2007. I met him in 2013, and he kind of convinced me that this was something that was very beneficial to patients. They had had no options for reverse total shoulder and needed an option for massive irreparable rotator cuff tears. He, however, was using fascia lata to recenter his humeral head, and I felt that doing a dermal allograft might be more beneficial. He presented in 2013 his 2-year outcome results, which showed some pretty incredible outcomes. And from that, we started talking about a new technique here in the United States. We started using dermal allograft as an alternative to his autograft fascia lata in order to be able to preserve patients' tissue and not have that hip incision be so painful. Our 2-year outcomes that we published in 2017 showed very similar outcomes to Dr. Mahata's, with an improvement in Acromio-Humeral distances, a diminishment in pain, and a significant improvement in ASES scores. At 5 years now, we're starting to see very impressive outcomes that are actually being maintained over time. This is actually my very first patient who, in fact, shows, even at 5 years, excellent improvement. She originally was a school teacher, going to have to retire because she couldn't actually run the board. After the SCR, we saw some very impressive outcomes, and she's been able to maintain her work as a teacher. Her only limitation being she has some endurance issues overhead. Pre-operative imaging, we actually saw that she had essentially no rotator cuff. She'd had numerous surgeries before attempting to repair her cuff, which all failed. You can in fact see some of those holes and anchors still in place on her humerus. During surgery, we were able to see that she had a massive rotator cuff tear in these massive holes and anchors hold in place using some actually cement to hold it in place that was dissolvable. Implant our graft, and you can see from inside the joint that it actually looks almost like a native rotator cuff. 2 months, 3 years, and 5 years post-op, the x-rays look well preserved. No evidence of progression of any kind of arthritis. We see no significant increased acromio-humeral distance that was getting worse. We see in the MRIs at pre-op 2 years and 5 years that the graft likewise is well preserved and in place. Ultrasound revealed to us that in fact the graft had thickened over time, going from a 3mm implant size up to 4mm at the time of reassessment at 5 years using ultrasound. We also noted that her ASES scores, VAS scores, all were doing quite nicely as well, and her age distance had gone from roughly 2 to 7.4. That resulted in this study that we published in 2019, showing that the graft actually can hypertrophy. And in fact, we also saw vascularity that was apparent with 1 year. This correlated nicely with other histologic and arthroscopic findings seen by other physicians. We noted that in the first 12 months, we would see the thickening of the graft occur primarily at the greater tuberosity. We took this measurement and then 5mm increments going medial from there. In the measurements, we're seeing that anything that's close to the tuberosity showed improvement and increase in size, whereas when you get towards the center of the graft, it was maintaining its original 3mm size difference. At over 12 months, we actually were in fact seeing a significant improvement at that greater tuberosity level with maintenance of the other measurements that we saw from there. Intrasubstance was very impressive. Using the Doppler function ultrasound, we were able to identify that intrasubstance pulsatile vessels were occurring usually by about 4 months and were present for approximately 1 year, after which they would go away. What's nice about this is that there are vascular channels that are built into the dermal allograft, which look like are being used by the body to help vascularize the tissue. Explant, courtesy of Dr. Evan Letterman and LifeNet Health, we were able to see that blood vessels were in fact appearing in the graft itself. What we also found is that in normal rotator cuff vascularity, there's no pulsatile vessels within the graft itself, but there is perigraft vasculature that appears between the supraspinatus and the deltoid. In fact, after about 1 year, these reappear on the surface of our dermal allograft. This other picture, courtesy of Julie Bishop, post-op from her SCR, illustrates this point nicely. We see it very well on ultrasound as well. But over time, we've been seeing that most of the studies that have been published in the past couple of years have in fact mirrored the results by Dr. Mahata, except two of them. Two of them have shown a very large increase in failure rates. However, when you go and look at the studies, you'll understand why. There are problems with technique primarily, also with not having done enough of them, and multiple surgeons, which one of the studies admitted there's a high failure rate in the first 5 to 10 cases of a lot of these surgeons. However, that only indicates exactly what we've been saying. In this situation, technique truly matters. And so understanding how to do it properly is a key to success. If you just try to slap a graft in there, it will not necessarily function because we need it to be a stabilizer. It is not simply just a spacer. If you're going to put in a graft of 6 to 9 millimeters, then yes, it can actually work as a spacer and you will get some improvement in function and pain. However, if we truly want it to be a stabilizer, then the actual tension of the graft is critical. And setting the tension is going to be critical for arm position. If you're going to measure the graft and pre-punch the holes as we recommended originally, that will help you set the tension. But to do so, the arm has to be positioned and actual measurement of the distances between your anchors is what's going to be the most important thing. This is why. If you take this model and show the glenoid with 2 anchors in place and the tuberosity with 2 anchors in place, if you move the arm, it changes the relationship of the distances between those anchors. So where you actually put your arm prior to measuring will determine exactly the tension and actually how that graft will sit inside and how it will function. We recommend neutral, 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 but as you can see, if you internally rotate, it will change that relationship between the anterior as well as the posterior anchors. If you abduct it, it will shorten the distance. What essentially is going to happen is you could potentially either make it too loose or too tight, and then it definitely will not function properly. Also, where you put that arm position in terms of beach chair versus lateral decubitus also matters. As we know well, lateral decubitus results in abduction and tension, meaning axial load, as well as too much internal rotation. It's harder to determine where neutral is. So we definitely recommend beach chair in order to position the arm well and then be able to set the tension correctly. Setting the tension is based off of pre-punching those graft holes once you have proper measurements and proper arm position, as well as accurate measurement of the distances. The problem is, even if you set the arm correctly, but then put in too much looseness of the graft or not enough tension, it won't work. We also know that some of the research done by Dr. Mahata indicated that posterior margin convergence of the graft to the infraspinatus was critical. We agree. However, he also indicated in his research that anterior margin convergence was not necessary, but this was for fascia lata only. This does not apply to dermal allograft. Fascia lata is a much stiffer material to work with. Fascia lata is also something that will not move much. So therefore, in using dermal allograft, which is elastic, we have to take this in consideration. That the ratio of transverse contraction strain to longitudinal extension strain in the direction of stretching force, which is Poisson's ratio, in a set point in time will indicate that if you actually pull on the graft in one direction, it will constrict in the other. But the correlate applies that if you hold that tension and prevent constriction, it will prevent elasticity. This is a key point. What this indicates is if we fix the graft anterior and posteriorly, we'll limit extension and elasticity of our graft and it will hold better. So at this point, anterior posterior over tightening is going to be also important. We don't want to over tighten that either. Otherwise, that would be equivalent to rotator interval closure, which will increase our joint reaction force. We do want to fix that laterally to the subscap if no interval tissue is there, but we don't want to fix it medially at the anterior aspect. Medial lateral over tightening will actually also increase that loss of fixation or rip through the graft. So medial lateral over tightening also should not be done. So a discussion of arm position is going to be secondary to proper tensioning. So my personal experience, at this point, this is kind of what we've come up with. In the top part of this kind of illustration, we're seeing essentially types of rotator cuff repair that I recommend. In the bottom part of this illustration, we're seeing when it's just too big. If it's repairable, if there's acceptable tension and poor tissue quality, we actually recommend doing a standard repair with graft augmentation. However, if it's greater than 3 centimeters and irreparable and unacceptable tension or even just poor tissue quality, an SCR is going to be recommended. That will then give us the ability that if that rotator cuff is mobilizable after we've done our SCR, then it can be repaired and we can do a full cuff repair on top of it. If not, we simply will do a partial cuff repair or just simply anterior and posterior margin convergence only. If it's fully irreparable and they have significant arthritis, and then of course, potentially if they're just over 80 with poor medical condition that can't handle a long procedure, potentially a bar procedure or reverse total arthroplasty might be indicated. So in this situation where we have an SCR that needs to be done before a massive cuff repair, in this situation, we see that the graft is mobilizable, but it goes just to the margin. But when we put the SCR in, it reduces the head down and allows that rotator cuff repair to be done fully with much less tension. The massive cuff repair then has a greater chance to function and be intact and survive. So what we've found is that we've done about 41 SCRs only, and the average range was equivalent to our SCR plus massive rotator cuff repair on top, which we've done about 8. What we found is that if we look at just all SCR comers and our historical controls of massive rotator cuff repair prior to the advent of SCR, we see that SCR did much, much better. The ASES scores reflect the same thing. If we take all SCR comers, we actually find that our AH distance improves and is able to be maintained. We also see that if we take our SCRs against our SCRs plus massive cuff repair on top of them, in fact, our massive rotator cuff repair on top of an SCR does better than our standard SCR. That's both on pain scale and ASES scores. We also see activity scores also, as no surprise, being significantly better with our massive cuff repair on top of an SCR because of the fact that we've actually reestablished the rotator cuff, which can function. The AH distance likewise does much better with an SCR plus a cuff repair on top. Shouldn't surprise you considering that we're adding more tissue in that region to be able to buttress up. And so in addition to working as a stabilizer and reestablishing the cuff, we are in fact creating a bit of a spacer by doubling up the area by having an SCR as well as a cuff on top of it. So at this point, my indications are that massive supraspinatus and or infraspinatus tears with poor chance of healing is more critical than worrying about being irreparable. The other indications of failed conservative management, intolerable shoulder pain, subjective unacceptable dysfunction, and middle glenohumeral arthritis also apply. Contraindications are definitely moderate to severe arthropathy, bone defects, absence of subscap, deltoid lat dorsi or pec function, shoulder stiffness, and size greater than 4 centimeters anterior to posterior. What was very interesting is when we brought all that data together. So what we took a look at is our green line here for our pain scale is SCR only. The red is, again, our historical controls prior to the advent of SCR, of massive rotator cuff repairs. The yellow is a current post-SCR only massive rotator cuff repairs, and the purple is a massive rotator cuff repairs plus the augmentation. What's interesting is that ever since the SCR has been come into play, our massive rotator cuff repairs have done much better, which shouldn't be a surprise because all those people who were really not a candidate for massive cuff repair, who were going to fail, are now being placed into the SCR category. So our outcomes from our massive cuff repairs are significantly improved. And it means that we're being able to tailor in for our patients exactly what is going to be the best solution to catch their problem and fix it and actually stay fixed for a long period of time. So if we take a look at our ASES scores, again, no surprise, same kind of situation. Once again, our current massive cuff repairs are actually doing the best. Massive cuff repair plus augmentation, kind of right there with it. And SCR just below, which shouldn't surprise us considering that we don't have a cuff. We just have a situation where we're trying to fix the system and make something work, but not ideally, not perfectly. And of course, our historical controls did the worst. Thank you very much.